for us, the problem was, how do we bridge the gap between fourth-year medical students and residency? We don't know where they came from in terms of how much experience they had in medical school, and we don't know where they're going. If somebody like me who's had a lot of experience, or like Chanel, is going to go to somewhere that is an ultrasound desert, or if they're going to go somewhere where their skills are going to really be nurtured. And so our main need is going to be not so much a curriculum thing. For us, we figured a lot of the resources are already out there, the material is out there, the content is out there. But the really difficult part is getting the buy-in to actually make room in the curriculum to get things done and actually start to provide these resources to the residents. And so we need buy-in from residencies, from residency directors, from the specialty boards, all 24 of them, hospital administrators, because they're going to have to actually, find funding, things like that, and the different associations. Different associations create different standards, and we really need to get them on board as well. And the second need is, how are we going to pay for it all? The moment you go to anybody is, where is the funding going to come from? So those are our main needs. The target audience, initially we thought the target audience were the residents themselves, right? Because they're the ones being trained. But at the end of the day, the target audience really is the patient, and how well is their health care, and are we putting in a central line completely blind, or are we actually putting, doing ultrasound guided procedures for patient safety and better health outcomes? And so they're really the target audience, and that creates a target audience need of, then I guess we have to train the residents better. So our goals were not so much to develop curriculum, but how do we actually get the curriculum in there? And the issue is all the curriculums are so inconsistent, and without the buy-in, we can't get a consistent curriculum. So we decided that our short-term goal is to develop minimum ultrasound competencies per specialty. What is the most basic thing you expect a resident that rotates or that is coming through to know, whether they're in dermatology or they are family resident, whatever it is? What is the minimum that we want them to know? Like, we expect them to know ACLS, right? Do we expect them to be able to identify a beating heart, turn on the machine, things like that? Do we expect them to be able to do IV access, things like that? And the long-term goal would be, this is news to me, but David was saying that there is a House resolution in 1999, Resolution 802, that actually is calling for every specialty to develop their scope of practice. What if we actually ask them to develop their ultrasound scope of practice? What is it that we want each specialty to know, right? What is it that they see every day that they can get really, really good at, and make sure that their residents know that as well? And so the long-term goal would be for each of those specialties to develop their scope of practice within ultrasound. And again, the secondary goal would be to secure funding, whether it's through public tax dollars, through patient safety initiatives. If we go to, one of the American Heart Association and talk about, we can actually see ultrasound, are they going to endorse it and help us find some funding? If we go to AARP, are they going to help us find some funding? So that's going to be also one of the goals. The educational strategies, it's not so much how do we teach people ultrasound, but more how do we inform people about this? How do we actually get the buy-in? So we need to come up with ways to inform hospital administrators, residency directors, and the 24 medical boards. And we need to, in order to do that, we have to provide and begin to produce more convincing research. Whether it's research produced by our MD MBAs that can take our skills and the great things that we see with ultrasound and have them put it in terms that a hospital administrator will understand, and put it in terms of dollar signs that will be saved, or lawsuits that will be prevented. And also, the major organizations, again, that can leverage our message, that can really go out there and continue and join our mission and say, AARP wants this for all their members. They want better patient care. So implementation, how do we do this? The AMA put out their call for proposals for, it's due June 15th, for Chicago in October, and we thought we could submit, if they're calling for disruptive curriculum change, there is nothing more disruptive than this. It is active learning, it is integrating a lot of different skills, and we could put together what we're calling 2020 Ultra Vision, right? And the other thing is, through brainstorming sessions like this, and whenever we go through, SUSME, AUM, all the different organizations, when we get together, we really do come up with great things. So continuing to write those white papers that convince people that this is a need. The driving force would be creating a task force or a committee section within SUSME of volunteers such as yourselves who are really interested in seeing this through, and calling on AIUM for support of resources and other support that they can offer, and meet regularly. And finally, how do we evaluate this? How do we see if we're actually doing anything good? Are we actually moving forward? So if we create a task force within SUSME, at the annual meeting we can meet up and see where are we, right? We can evaluate the progress of the 24 ABMS boards to see how many of them are actually doing this. Within each specialty, how many residency programs have actually developed it, and then, but allow for some flexibility, because minimum competencies in ultrasound and the maximum, which is the scope of practice, may be different for somebody in emergency medicine versus somebody in pathology or psychiatry, right? So allowing for some flexibility within this proposal, allowing for some flexibility for people who don't have the resources, for people who don't have financial resources, or they don't have faculty that are already on board and super trained, right? And allowing them for a request for an extended timeline to implement this, because our timeline looks like this. In the first year, we want to make sure that everybody gets informed about what the need is. We need residents to have a more consistent curriculum, and we need them to have minimum abilities in ultrasound. By the second year, we want each of those boards to develop what the expectation will be, what are those minimum competencies. During third year, it would be great to see them start to implementing it, right? Actually holding their residents accountable for this and their faculty and everything. And when we come together, say, hey, how are you guys doing? How is this working out? Who needs help? Because, Dr. Fox actually knows a great pulmonologist who might be able to go over there and train you guys. So we don't really need to develop the curriculum. We just need to be able to start networking and connecting people to the resources that they need for the actual education. And by the fourth year, begin to ask people to start developing, what do you think a scope of practice would look like for your specialty? It doesn't have to, you don't have to commit to it, you don't have to, just start to think about what it would look like. And by 2020, actually begin to see people implementing this and testing them out and achieve our ultra vision.